Welcome, everyone, to the January issue of the Alfred Emergency Podcast Journal Club. My name is Dr. Danny Marhaba, and I'm your host. We are joined today by Professor Peter Cameron, one of the emergency medicine consultants at the Alfred Hospital, and Dr. Rob Melvin, also one of the emergency medicine consultants at the Alfred Hospital, and one of the authors of some of our publications today.
Paper 1.
The first publication we will discuss today is the FORCE study, which was a randomized controlled equivalence trial in the United Kingdom. It was a prospective cohort-controlled randomized equivalence trial for children aged between 4 and 15 years of age with a distal radius buccal fracture, who were offered either bandage and immediate discharge with follow-up, of course, or rigid immobilization with a splint back slab, with the primary outcome being pain at 3 days as self-reported using the Wong-Baker Faces scale, and a host of secondary outcomes, including patient or parent-reported function, satisfaction, use of analgesia, school absence, and complications within 6 weeks of follow-up. The sample size was determined using the minimum clinical important difference of 1 point on the Wong-Baker Faces scale. And the calculation was that they required 278 patients of each arm because they used 2 different age groups. One was between 4 and 7, and one was 8 and 15. The study and the target populations were largely similar in age and proportion of sex. And the intervention and comparator were both measured. So both the bandage and the control, which was rigid immobilization, were measured as categorical nominal values with the type of splint recorded by the clinician placing it. The results or the findings of this trial were reported in the manuscript, and pain was equivalent at 3 days with measures of 2.08 versus 3.14. And the authors conclude that this trial found equivalence in pain at 3 days in children with a buccal fracture of the distal radius who were assigned to either the bandage group or the rigid immobilization group. And so my first question on the FORCE trial goes to Professor Peter Cameron, and it's a odd question, but this one is, what's an equivalence trial? Because my understanding was most studies that we do tend to measure or to look for a difference.
To demonstrate equivalence, you've got to look at both sides of the tail. So you've got to, that makes it harder in some ways to demonstrate equivalence than superiority or inferiority, because they're sort of one tail. So the problem, we haven't got a placebo. So basically, in a lot of drug trials, they're trying to show that one drug's sort of roughly similar to the other, or, in this case, one treatment is roughly the same as the other. So that's what equivalence is. What test you use, is the subject of, quite a lot of discussion.
And so you have to prove that it's not greater than a certain difference and it's not less than a certain difference. And therefore, we presume that equivalence is implied within the pre-selected margins.
And the thing about what is less or more is, again, it's got to be clinically relevant. There's, 1 point on a Wong-Baker scale that doesn't sort of, at 1 day or whatever doesn't fuss me too much. What would fuss me a lot is if there was a difference in, re-fracture or need for surgical manipulation or something concrete that would, make a difference when I was advising the parents, about what I wanted to do. So, so in this case with the Wong-Baker scale, they needed a bit of extra Panadol or something. Does it really matter? Especially when you take into account the inconvenience of using immobilization and so forth. So,
and so you would like to see potentially even more outcomes that were of interest to you.
No, I'm happy actually with this paper. To get into the meat of it, at the end of the day, there was one patient where there was, a change, and there were no patients that needed surgical remanipulation. So That's out of 1,000 people. I mean, that's pretty incredible. It suggests that it's a fairly harmless, in inverted commas, injury. And from that point of view, really, it may be that you get a little bit more pain relief or, maybe a little bit less discomfort, whatever. But in terms of the things that matter to us as clinicians most, there's nothing to see. So, whatever's most convenient for the parents and the patient themselves, to me, is the thing that you should be doing.
That makes sense. Rob Melvin, your thoughts on what Peter said?
Yeah, thanks, Danny. And I really like this paper. It reaffirms to me that a bandage and advice to the child and to the parent that, you won't have a bad outcome from this injury. This paper sort of shows that, as Peter's already mentioned, that none of the children needed surgical manipulation. And your healing will be the same whether you wear a bandage or whether we put a splint on. And you might have a little bit more pain and require some paracetamol or other very simple painkillers for a couple of days, more so with the bandage than with the rigid immobilization. But as a parent, the difficulty of managing a splint particularly in a younger child, this paper shows that it's not really necessary. You've got equivalents with a bandage and maybe some extra painkillers. So I think it's really useful paper to be able to say to parents in particular, to say, look, a bandage is fine. Some painkillers, if your child is fine with taking painkillers, they're going to be absolutely fine and in a few days' time and will have no adverse long-term outcomes from the injury. So I really like the paper.
Now, Alfred Health runs 2 campuses. One of them is a community hospital, which sees a lot of pediatric patients in Sandringham. And Rob Melvin, you have a fairly significant role in running that department specifically as well. And so my question is, with any adjuncts such as wrist splints, do you find a role or see a role with wrist splints in that environment, if it's even necessary?
Well, I think in this paper shows that in children, it's probably not necessary. And my role at Sandringham is I'm currently the acting director there, and so have a oversight of the types of injuries we get. And as you rightly say, at Sandringham Emergency Department, we see a lot of children with forearm injuries, a variety of from everything from a torus fracture through to supracondylars. And again, going back to this paper, states to me that in a torus buccal fracture with distal radius, children can be managed with a bandage rather than needing a splint. And I think although there's some cost associated with wrist splints, both to adult ones and to children, I think they are generally a good option. If that's what you're asking, Danny, they are a good option rather than necessarily needing a plaster of Paris splint. So I think they're a good option to have, but in this particular injury, as this paper shows, you're just as well using a bandage and patient education.
Thank you. My last question goes to Peter Cameron. Prof, in the meat of the paper, they included kids with distal ulnar fractures. Does it usually change your thought process when you see a distal ulnar fracture with a buccal fracture, or are you comfortable that the ulna primarily deals with the elbow joint and the radius primarily deals with the wrist joint, and you just make sure that it's not a green stick? What are your thoughts on the inclusion of ulnar fractures within the just bandage group?
I think, this paper didn't look at that difference, so we can't, all we're doing is extrapolating. But clinical experience would suggest that if it's a buccal fracture, it's a buccal fracture. And it doesn't really matter where it is. And so I would be sort of comfortable extending it to the ulna, even though there's less patients and so forth. But, if you wanted to really test that scientifically, you would need to actually
isolate for it and test it separately.
Yeah. But I think, I think most clinicians would say a buccal fracture is a buccal fracture.
Any more thoughts on this paper before we move on to the next one?
No, I think, these sort of studies, it's very simple, it's very, practical, but important studies, as Rob mentioned, because it's sort of what we all think, in our back of our minds before we say to a parent or whatever, this is what I'm going to recommend. It's nice to have this to sort of back you up and say, well, there was a large study with 1,000 patients and it came to the conclusion. That sort of just makes it all feel a lot more solid than, in my experience, this is a nice way to do it.
And it gives you evidence when you're having a chat with parents to be able to cite.
Yeah.
Rob, do you agree? Do you foresee yourself sort of citing this at some point to parents and saying, look, this is the evidence we do have?
Yeah, completely agree. Some parents have more health literacy than others, and many parents will be very much guided by you as the expert managing these kinds of patients who don't need an orthopedic surgeon's input. So this paper does give me that evidence to present if asked by the parent or if I feel that I need it as part of my explanation of what we're doing.
So one other thing that we didn't discuss was the follow-up, and I think that's equally important. I mean, our orthopedic clinics and things are overrun. To be able to just sideline this whole group of patients and say, don't need follow-up is very important.
GP follow-up, yeah. Thank you both. We will move on to our next manuscript.
Paper 2.
Which is a manuscript that is dear to us. It is the MAPPAED study, which was published in Emergency Medicine Australasia. It's the mid-arm point in pediatric study, an effective procedural aid for safe pleural decompression in trauma. The target population was children less than 18 years of age attending any of 4 emergency departments located in either Australia or Ireland who required a chest x-ray for any reason. And the intervention was the mid-arm point was measured. We do this in adults in many hospitals. The mid-arm point was measured and the chest wall was marked at that level in these children. A radio-opaque sticker was then placed on the mark and an x-ray was taken with these arms abducted. The comparator for this study was effectively the presumed gold standard of intercostal spaces 4 to 6, as identified on the chest wall x-ray by a consultant radiologist. And the outcome was the proportion of markers localized to the correct space, intercostal spaces 4 to 6, through the use of the mid-arm point by interpretation of a consultant radiologist versus compared with those that were in intercostal spaces 1 to 3 and those that were identified as intercostal spaces 7 to 8. It was a prospective cohort controlled trial. The sample size determination was pragmatic. They collected the data that they could. The intervention and the comparator were measured using a tape marking measure to find the mid-arm point of the adducted humerus. And they measured from the acromion and the olecranon as bony landmarks to measure to the midpoint. And then they used a pen to mark. And then they used that radio-opaque marker. A total of 392 children participated. Some of them had both sides marked. And they found that 83% of the markers were sitting within the safe zone for pleural decompression. Interestingly, the authors noted during their analysis that in children above the age of 4, these patients were much more likely to have their markers placed to caudally. And so they initiated a post hoc analysis where they introduced a modifier or an adjustment. They found that the best adjustment they could introduce was that children more than 4 years of age, should they raise the marker by 1 intercostal space rostrally or superiorly, one rib space above, they would get more accurate results in that patient group. The conclusions of the authors were that the MAP technique, the mid-arm point technique, reliably determines a safe site for pleural decompression in children with an age-based adjustment. The mid-arm point in pediatrics rule, they label it. In children aged more than or equal to 4 years, use the mid-arm point and go 1 intercostal space up to hit the safe zone. Whereas if they're less than 4 years of age, use the mid-arm point. That's a lovely conclusion. It's a conclusion that's helpful and easy to retain. First question goes to Dr. Rob Melvin. Are intercostal catheters or finger decompression thoracostomies in children a common procedure?
They're not a common procedure in Australia, but worldwide, and paediatric trauma is one of the leading causes of death. And whilst I'm not suggesting that our study done across a number of centres in Australia and one centre in Ireland is immediately applicable to every country in the world. I think it is a simple, time-effective measurement to use, which is going to give you 9 times out of 10 is going to get you into the safe triangle where the pleural decompression needs to occur. So the other thing to say is, whilst in Australia, paediatric trauma-related pleural decompression is uncommon, when it does occur, it's an incredibly stressful environment. Children often have a great capacity to cope with significant illness or injury until they don't cope. And so to be confronted with a large traumatic pneumothorax in a child who's been in a motor vehicle accident, who maybe is brought to your emergency department, which isn't a trauma centre, then to have this, we hope as authors, we hope that this rule will allow you as an emergency clinician to take away some of the stressors associated with that situation and to use this measurement to accurately and safely place your intercostal catheter.
Especially when current practice, give or take, involves us placing the catheter outside of the safe zone around 50% of the time, if you believe some of the data.
Yes, some of the previous data. And look, this is a very difficult area to study because at least in Australia, pediatric trauma, major trauma is uncommon. So as you stated in your summary of the study, to have over 700 markers placed on, children who are having x-rays for other reasons, but we've got sort of 700 measurements that have been used to come up with this rule, which has been validated with consultant radiologists. I think you're never going to get 700 pediatric trauma cases enrolled in such a study. So it was a nice, concise study done multi-center and internationally. And it was we would have recruited more participants had it not been for the start of the COVID pandemic, which is when we had to stop recruiting.
No, definitely. Thank you. Peter Cameron, what new information do you take from this data set and this analysis?
As Rob's already said, the ability to do this in real patients is zip, certainly in Australasia. And this was an elegant way of getting around that, because the real issue is, can you estimate where the safe triangle is? And this study demonstrates that most of the time you can. I was a bit surprised that it wasn't a little bit better, in inverted commas.
As in the accuracy of the mid-arm point in kids.
Yeah, but there are a number of things that come into it, like habitus and all this sort of stuff. But as you stated, previous studies have shown that, clinicians, especially those unfamiliar with performing these procedures, get it wrong quite commonly. This would definitely increase the hit rate in the correct area more often. And even though it was a sort of almost a limitation of the study, the idea that you could, with the older children, just by moving it up one, make it better, actually is quite a useful thing when you're sort of trying to work out exactly where to put the catheter. It's actually something to remember that it's more safe to go up rather than down, because, if you've got to go somewhere, then it's probably better to go up.
Because most of the malplacements or suboptimal placements, especially in kids greater than 4, were too caudally, too down.
Yes. And, I part of my role in the state trauma system has been to audit it for the last 20 years. Intercostal catheters are one of the simplest things we do, but they're also one of the things that cause, a lot of the complications, and anything that makes it easier. And this is a very simple, practical study, and congratulations to the authors on getting it out there, because it's another aid. It's not foolproof, and if if they're big or deformed or in some way it's difficult, you need to obviously correlate it with the clinical situation, but it's another useful aid.
Dr. Melvin, so you're an author on this study. What are your thoughts on the challenges that you faced and future directions in this area of evidence?
I'd like to acknowledge the other authors, and in particular lead author Dr. Nuala Quinn and Professor Warwick Teague at Royal Children's. It was a study that came together over a teaching forum, a sort of multi-hospital teaching forum where we discussed there's no evidence in pediatrics for this, what do people think? It actually was an interesting process to get it up and running across multiple sites, requiring, ethics at every site, because ethics in pediatric studies are even more rigid and difficult to obtain than in adult studies. And so there was a few challenges initially around multi-center ethics approval. And then the lead author moved countries back to her home country of Ireland. And actually that helped in many ways, because then she was able to recruit patients from another centre, just, again, broadening the breadth of patients that were recruited. And from my personal perspective, we recruited nearly all of these patients at our Sandringham Emergency Department, which is a much smaller centre than the Alfred, but it does see quite a lot of paediatric presentations, about a third of our presentations. So this really pleasingly to get some research done at Sandringham Hospital. It shows that all, even smaller emergency departments can have the capacity to be involved in research. And I was really pleased that we were able to do that from Sandringham Hospital, because from an Alfred Health perspective, nearly all of our research comes out of the Alfred Emergency and Trauma Centre.
Thanks both for your thoughts. I thought it was a great study. I definitely will carry some of the conclusions on with me, because it's the best evidence we have in this particular topic to date.
Paper 3.
Our next manuscript is titled Early Post-Injury Screen Time and Concussion Recovery. It was a publication in the journal Paediatrics in 2022. Target population was 8 to 16-year-olds who presented to the emergency department within 48 hours of sustaining a concussion or orthopedic injury. The intervention or the exposure, I should say, was the amount of screen time these kids were subjected to. Comparator was a group of orthopedic injured patients. The outcome was the post-concussion symptom severity. It was a cohort-controlled trial. The authors state that the study was a planned secondary data analysis of the Advancing Concussion Assessment in Pediatrics, the ACAP study, which was a prospective longitudinal cohort study of children and adolescents who sustained a concussion or orthopedic injury. The outcome variables used were the health and behavior inventory. It's recommended as a primary outcome measure in the National Institute of Neurological Disorders and Stroke for sports-related concussions. And the results were that screen time was found to be a significant but non-linear moderator of group differences in post-concussion symptom severity for parent-reported somatic as well as self-reported cognitive symptoms. They found that both high screen time, but also interestingly low screen time, were associated with relatively more severe symptoms in the concussion group compared to the orthopedic injury group during the first 30 days post-injury, but not after 30 days. The authors conclude that high screen time in the first 7 to 10 days was associated, but not strongly associated with worse symptoms, and that low screen time was also associated with symptoms, and they were relatively more symptoms, or slightly more severe symptoms. They also found that other risk factors were more important in predicting post-concussion symptoms. And so the authors conclude that these findings support advising moderation rather than blanket restrictions in screen time, especially after the first 48 hours. There was a conflict of interest. One of the authors, Dr. Yates, was an author of the Health and Behavioral Inventory, but he didn't derive any income from it. My first question goes to Peter Cameron. Do you take much change in your practice from the evidence that's provided here?
No, I found this a fairly difficult study to interpret, to be honest. I always worry about cohort studies where there's an association because there are inherent biases in these associations. So it's interesting they found that a lot of screen time or a deficit of screen time both had correlations. And you can imagine if you were off the planet, with a post-concussion syndrome, you wouldn't
want to watch TV.
But then again, you might just be staring at the screen and not taking it in. There's sort of lots of ways you could interpret that. And I'm not, I'm presuming, I know they didn't actually look at how they were interacting with the screen which would be quite important. So in terms of interpreting their association, I think it's very problematic. So that's the first point. Second point is in terms of, advising parents and so forth. I mean, there's studies going back 20 to 25 years showing the factors that are important, and they haven't really changed. So, people with pre-existent problems, people who are, type A personalities, people who are anxious or depressed or whatever, all these things help to predict people who run into trouble. And in terms of intervention, the single most important intervention that's been shown to make a difference is to tell people they're not going to be able to concentrate well for the week after the injury. There are some, for people who have ongoing symptoms, there are some strategies that therapists can help with, but that's for a very small percentage of the total. But in terms of screen time, I mean, clearly you wouldn't be advising mum and dad to, either spend a whole lot of time or to ban it. I think to ban it would be probably problematic as well. So, moderation is, like most things in life, is generally good for health. As we discussed at the Journal Club, I think as a parent, you would find it very difficult to ban a child from screen time.
In fact, you could say they tried, not these authors, but McNow and all had a prospective randomized controlled trial not last year anymore. In 2021, and they tried to get parents to ban or to say no screen time, and they found an average of 45 minutes per week in that cohort, compared to around 3.5 or 4, I don't remember, hours in the OK screen time group.
And as you know, with child behaviour, if you say you can't do it, then generally you fail. If you say if you try and limit it, you've got more success. But I think, clearly you wouldn't want the kid to be just sitting in front of the screen for hours on end. But saying that you should ban it, I don't think this in any way correlates with that. I really don't think it makes any difference from the current recommendations with regard to screen time.
Rob Melvin, what do you tell the parents of kids that you see?
I like Peter, didn't really take much from this particular study. I do think it's presumably in the paediatric world is a burgeoning area of research, because particularly tablets now and children's use of tablets for both for schooling and for socializing and entertainment, in the last 5-10 years, at least in many areas of Australia, has exponentially increased. So I'm sure there are probably some better studies being undertaken at the moment around, maybe tablet use. You've got to be a bit more specific than screen time, because that just covers so many different modalities. But maybe tablet use after a head injury, is more or less, maybe there will be some evidence that comes out in the next few years around that, because, children playing games on a tablet is very different to a child watching Peppa Pig or Bluey on the television, in terms of the interaction and the way that the brain maybe has to work. So this study doesn't help me at all, but I imagine that there's going to be increasing papers, publications around maybe specifically tablet use in the next couple of years.
I think one improvement could be, there's no reason why you couldn't have an app that measured the time and the type of activity. And that, as Rob's saying, would be much more useful, because I think watching, Bluey or something is very different to playing an interactive game and doing educational resources.
Especially a complex game like Tetris. But that's interesting because iPhones currently do monitor our time, and they give us weekly reports sometimes.
Yeah, well, I'm sure some of our Google friends and so forth would know a lot about what we're all doing.
Fair enough. Any advice, Rob or Peter, to registrars, trainees, or other docs in the emergency department about what to tell parents?
There's very good instructions now on how to manage concussion, some of which is evidence-based and some of which is consensus-based. But as I said, the strongest evidence is reassuring people that, they won't be quite right for a week or two is very important. Giving them, online, there's good online material now with the children's and other guideline groups. with this sort of information on them. And as I said, for those with persistent symptoms, there are, depending on what the exact problem is, sometimes it's purely a middle ear problem. Sometimes it's, they've got cognitive problems, concentration problems. Each of those has specific remedies. So if they've got persistent symptoms, it's worth identifying exactly what the issue is. But that's, first week or two, I think it's just a matter of reassuring people that that's normal.
Rob Melvin?
No, I agree. I think, there's so many variables in terms of the type of injury, the age of the child, the personality of the child, their baseline screen time. Are they primary school age? Are they secondary school age? There's too many variables to give sort of just uniform advice. But I agree with Peter. In general, I like to say to parents, if their child has had a type of concussion, is that the brain needs a bit of a rest, particularly for these first few days, maybe up to a week. I can't tell you for sure exactly how long a recovery back to baseline is going to occur. And they should watch out for maybe activities that make the child worse. For example, it might be screen time, but it might be television, it might be listening to music. So there needs to be a bit of a patient-centered approach depending on all those variables.
Thank you both for your time. That was Professor Peter Cameron and Dr. Rob Melvin, both consultants at Alfred Health. I was your host, Dr. Danny Marhaba, and have a lovely evening.